Good evening, everyone, and thank you for being here with us today for this webinar. I wanted to share something personal with you. The only time I have faced homophobia as a proud out gay man was from a fellow health professional. It emotionally obviously scarred me, but it also empowered me to start an initiative called Health Professionals for Queer Indians, where our idea is to sensitize healthcare professionals for the healthcare needs of the LGBT community. And Practo as a platform has come forward and organized this webinar for the very same reason. My name is Dr. Prasad Raj Dandekar. I'm a radiation oncologist in Mumbai, and I'm really pleased to be here today with all of you. Many of you may wonder, and I have had this experience in the past where people say, but I don't see gay people in my practice. I don't see transgenders in my practice. And the reality is that your patients or your clients may not be coming out to you. They may not be telling you. You may have a client who's under depression and anxiety, under treatment for many, many years. The root cause of their discomfort with their sexuality or gender may be the reason for it, which may never come up. So it is important for all of us, and especially as mental health professionals, to know about LGBT community, their battles, and also basics such as how do you address them? What is the difference between gender and sex and sexuality? And the aim of this webinar is to just sensitize everyone on these issues. And to do that, we have an excellent panel today, an international panel, and I'm really honored to be here with all of them. So without any delay, let me introduce Dr. Ajit Bhide to you, who's going to introduce the speaker for the day. And Dr. Bhide doesn't need any introduction as a mental health professional. He has been the past president of Indian Psychiatric Society. He's also the chairperson of LGBT Task Force of IPS. But more importantly for me, he's the man who stood up and issued a letter in 2018 saying that homosexuality is not a mental health, a mental illness, and should be decriminalized just before the 377 case. And it was used by 3 out of 5 judges in the Supreme Court. So he's somebody who has had a deep impact on the history of inclusion of the LGBT community in India. Thank you very much, Dr. Bhide, for being with us. Over to you, sir.
Thanks, Prasad. I'm very glad that this webinar is happening today. It's not a day too early. I think though the Indian Psychiatric Society took an official position as far back as 7 years ago, saying that we should decriminalize homosexuality and we should encourage the diversity, which is quite within the normal purview of human behavior. The LGBTQ community are not people with pathological orientations. Their orientations to sexuality, though differing from the very common one of heteronormative sexual orientation, are very much within the range of the normal. And what Prasad just mentioned was an official statement that we had to put down, because unless you put the things down in paper, nobody really listens to you. So the task force on LGBT during my presidency, headed, I must say, by a very determined young friend, Dr. Kersi Chawda. His co-chair on that LGBT task force was Amrit, who is with us today. I'm Dr. Amrit Bhattajoshi from Bhubaneswar. And the convener of that task force was Avinash D'Souza, who is also with us today. Kersi will be with us at a follow-up webinar at a later date. So when Practo, Dr. Ruchi Singh to be specific, and Prasad, a good friend from Bombay, and gay activist, non-pareil, approached us to have this seminar, I thought it would be very appropriate that we have the man who has led the world community in mental health to give us a keynote address. We are very delighted that with just one request, I had a response from Professor Dinesh Bhugra from London, to say that yes, he'd be glad to take part. Exactly what did we expect from him? And then I put him in touch with the organizers who gave him the specifics, I hope, to speak to us, to deliver a keynote address, so to say. Professor Dinesh Bhugra is an alumnus of the Armed Forces Medical College, And he then went on to the UK, where he has risen magnificently. We in India are very proud of him. And while he has been honored by the American Psychiatric Association and various other international bodies, we're still waiting for the Indian government to take our plea to give him the due recognition as a representative of India in the world community, especially in mental health, but not just mental health. Dinesh has been the dean of the Royal College of Psychiatrists. He's been the president of the Royal College of Psychiatrists. He's been the president of the World Psychiatric Association, and he is now the president of the British Medical Association. He is well known for his crisp, articulate style, both in his speeches as well as in his writing. He is indeed the editor of the International Journal of Psychiatry, and he is a multifaceted man with various interests, mainly focusing on the social, but not only that, of mental health, social aspects of mental health. He's been rendering yeoman service in the field of medical education, particularly psychiatric education, and he is openly gay and has sensitized very many professional to this phenomenon that we need not consider pathological. We never should have done. Dinesh, we are honored that you're here to deliver the keynote address, and over to you.
Thank you so much, Ajit. It's a real pleasure to be here. And I want to kind of start off by three things. One, that is absolutely vital to recognize that sexual variations are not psychiatric disorders. Two, that most of us are able to function in different ways. The orientation, which is innate, and we need to make a very clear difference between sexual behavior, orientation, and sexual fantasy. And these are very different things. I don't have a lot of time, so I'm going to sort of zoom through, no pun intended, the presentation. Basically, I want us to be aware that, when we talk about definitions, what do we mean? I mean, are we talking about statistical variations? Are we talking about deviation, who defines it and how it is defined? And one of the big challenges, I think, is how societies see sexual behavior. An American sociologist, Vern Bullock, talked about sex positive and sex negative societies. Sex negative societies largely deal with sex as a procreative effort. And so the main function of sex is to have children. And he notes that for a very long time, India was a very sex positive society where sex was meant for fun. And you can see those on the Khajuraho site and various other places, the fluidity of gender and sex and was much more accepted. But particularly following various invasions and colonialism, things have become much more difficult. And for a very long time, being gay was seen as a kind of political statement, not necessarily a kind of same-sex behavior. And that, again, in the last 30 years or so has changed. And there are a number of definitions and words being used, sort of queer, questioning, undecided, intersex, lesbian, bisexual, etc. And I'm not going to go through those, but it is something that we need to bear in mind, partly because that shows the range and it shows the heterogeneity of the group. So we can't see that one gay person behaves exactly like another. So it is important that when we look at attitudes to variation, and Prasad has already talked about that, how people respond in different ways without questioning or asking questions about an individual's gender identity or sexual identity. And a lot of attitudes, negative attitudes in particular to same-sex behavior, are about attitudes to masculinity and what men should be doing or not doing. And the rates vary between 1 to 16% of the population can identify themselves as homosexual or bisexual, lesbian, gay, or bisexual. And in immediately after the Second World War in 1948 to 1950, Kinsey did his surveys in the USA, where he created the 6-point scale and found that something like 10% of the population of the sample were gay. But what is forgotten that a lot of that sample were people who were in the army, away from potential sources. Therefore, the behavior could have been same-sex, even though their identity could have been heterosexual. So in order to understand sexuality, we need to understand feelings, identity, bodily differences, reproductive capacities, needs, desires, fantasies, etc. And particularly for women, they may arouse more anger and negative feelings. And having said that, when in Britain in 1800 something, law was passed against same-sex behavior, apparently Queen Victoria refused to believe that women do that, and it was only men. So in law, until recently, same-sex behavior against men was illegal. And we know bisexual means is a kind of dual mingling of sexual feelings. Is it dual attraction, equal or otherwise? And one of the interesting things that we don't talk about is the minority stress. As clinicians, we see it all the time. And there's been consistent evidence, and there's been some wonderful studies done by Hudson Buehler and colleagues in America, where they've looked at the effect of state level policies on the association between mental health and sexuality. And psychiatric comorbidity among LGBT individuals was 3.5 times that of heterosexual people. So mood disorder to be twice, anxiety disorder twice, substance misuse twice. But when same-sex marriages were introduced, sexual minority men had a significant decrease in mental health care visits, as well as a reduction in hospital visits. So there's a very clear role of social factors. And similarly, in a more recent study, again, Hudson Buehler and colleagues have found that before changes in law, LGBT individuals reported, behavioral difficulties such as smoking and obesity and so on and so forth, which again dropped. Similar findings from Australia, that it's also that women who identify themselves as bisexual or lesbian show high rates of self-harm, suicidal thoughts, consistently from across the world. And again, I think one of the bits that we need to bear in mind that the data which is missing is from low and middle income countries. And it's confirmed that LGBT people are 3 to 6 times more likely to attempt suicide, much higher suicidal ideation, depression, anxiety, etc. And we know that in addition to the sex positive, sex negative aspects of the cultures, there is issues related to micro identities, which are especially relevant to sexual variation. So you may have a psychiatrist who's gay, or you may have a gay psychiatrist. You have a male gay psychiatrist or gay male psychiatrist. So depending upon how those micro identities play a role. And as I said earlier, that sexual behavior is about what you do, who you do it with, and how you do it. Sexual fantasy may or may not translate into sexual behavior, and sexual availability, again, will determine how you behave and how you perform. And we know that 71 countries around the world are still using laws which make same-sex behavior illegal, and 60 something countries where same-sex behavior is punishable by death. And we know that our attitudes are related to age, ethnicity. I'm going to give you a very quick run through of some of the findings that we did in the UK quite a while ago, but doesn't seem to have changed. Psychiatrists, by and large, are most positive. Older doctors are more negative, and they see homosexuality as lifestyle choice and fear of heterosexuality, and that homosexuals are a danger to children. Young female doctors are much more positive and comfortable. Similarly, in medical students, religious belief play a major role. Um, 2 years ago, Nindya Kaur and colleagues in Calcutta reported that 22% of medical students in Calcutta Medical College felt that homosexuals were neurotic, 28% thought homosexuals were promiscuous, and 8% thought homosexuals posed danger to children, and 16% saw homosexuality as an illness. And one of the big challenges as clinicians is that we need to advocate, and we need to advocate for minorities. And there is a process of coming out. People decide who they tell, when they tell. People may come out later in life. People may have problems coming out in minority groups. And we did a study in London coming out in Asian gay men, and Muslims had much more difficulties. And when coming out, people told their friends first, then their sisters, and then the rest of the family. And there was very clear culture conflict. We did a fairly similar study in Bombay, and numbers were very small, but slightly over 50% were out to others, whereas about 40 something percent were not out. It was generally female friends, cousins, siblings. And in 15 out of 28, parents did not know. 18 subjects felt that they would make positive attempts at hiding their sexual orientation. And this is really frightening, that if we asked them if they would take a pill to make them completely and permanently heterosexual, 8 out of 28 felt that they would, because it would make life simpler. So, people got thrown out of their home, families broke all links with them. And there's similar problems with lesbians coming out. And I'm not going to go through hijras or trans in this context, but probably we can have a discussion. In the UK, in London, we did a focus group looking at bisexuality along with psychologist colleague Padmal De Silva. And we found that their subjective sexual arousal did conform to a bisexual pattern. But what was quite interesting was that they saw themselves attached to one or the other group. And in managing LGBT individuals, therapist attitudes are incredibly important. Therapist orientation and matching, we can have a debate about it, but particularly until recently, as we heard from Ajit, that there had been problems, same-sex behavior was illegal, so doctors were frightened of asking their patients, and patients were frightened of telling their doctors. So that should ease. And again, Avinash is going to be covering about LGBT parenting issues later, so I'm not going to cover that. But the challenge for us as clinicians is, should we self-disclose? How do we look at micro-identities and multifaceted nature of sexual orientations? And also, giving people labels may be oversimplifying, so we need to have a discussion about that. So what we need to bear in mind is that society changes. People are much more gender fluid, sexuality fluid now than they were 40 years ago. Attitudes to sexuality and gender have changed and will continue to change. Cultural values play a lot of importance and role in terms of coming out and accepting help. And we need to be aware that one of the major roles that we have as doctors is to advocate for our patients, to work with policymakers to bring about equity and equality. And it's very clear from the data that I presented from the USA that once law changes and equality comes into place, rates of psychiatric disorders and sexual minorities start to drop. So we need to think about different ways of engagement. And I'm really delighted that Indian Psychiatric Society took the lead, and that lead has paid off. And long may it continue. I thank you very much again, Ajit and Prasad, for inviting me and for giving me the time. I think I've gone over my time, so I'm going to stop there. We're happy to take questions later on. Thank you very much.
Thank you very much, Dr. Bugra, for that wonderful summarization of your experience in the UK as well as what's happening in the world, and very illuminating. And I think Dr. Amrit is going to go into the details of various identities now. But it was really nice that you brought in the minority stress, which has been affecting not just LGBT community, but many minority communities in all over the world, and how the majority community ignores that and also sometimes naturalizes those stresses to the community. And of course, the role of micro identity and sexual behavior versus sexual fantasies and sexual orientation. And I think the most important point that you brought out is the importance of the therapist attitude towards their clients. And that is why webinars such as this are very important, where we're trying to change that attitude. So Dr. Amrit is the next speaker, and it's a delight to introduce Amrit. Professor Amrit is a neuropsychiatrist and a wellness consultant at the High-Tech Medical College, AMRI, the Healing Touch. He's also the direct council member of the Indian Psychiatric Society. He's also the coordinator of WHO UNICEF IPS Committee to manage psychosocial health during COVID-19. And he's editor of Odisha Journal of Psychiatry. With so much of, accolade, you would expect an old man with a white beard looking wise like Dr. Bhide, but here it is a young, charming Dr. Amrit Patajoshi. Over to you, Amrit.
Thank you, Prashad, for the nice introduction. At the outset, I would like to thank Practo for thinking about this topic, a very, very important topic. I'd like to acknowledge my guru, Dr. Ajit sir, who has always been guiding me. Prashad, who has helped us, the IPS, in reaching to where we have been able to reach. Dr. Kersey, Dr. Avinash, Dr. Suresh will be coming later on. So I have a very important topic, understanding diversity within the LGBT community. Whatever be your intention, if you don't use terms properly, you are bound to create a lot of heartburn. And that is what has been an issue throughout the way we have been dealing with our patients in terms of the LGBT community. So naming is powerful, and historically, the power to name has been held by outsiders who designate and marginalize those less powerful as other. So that's a very, very important issue. And self and community are interwoven for many LGBTQ people, including many who live with mental health conditions. Just as there can be stigma and rejection against LGBTQ people in straight communities, LGBTQ people can experience representation in mental health communities. So conversely, people with mental illness can experience rejection in LGBTQ communities. Unfortunately, membership in one marginalized community doesn't guarantee acceptance in another. So there are a lot of issues which we as mental health professionals have been trying to take out, weed out. We are trying our best. We will stumble, we will fall down, but yes, we have a focus, and that is what we're trying to do. So coming to the presentation. So we use a lot of terms. Many of the people who are new to these things will suddenly get drowned in the number of things which come in, but many of them are intertwined. And if you are little alert, if you are inquisitive, you might not create a lot of heartburn, which you, without any intention or without any knowledge, you cause. So LGBTQIP2SA, it continues. We will be only dealing with most of the things which we come across in our common practice. So we have lesbian, we have gay, we have bisexual, we have transgender, we have queer, we have questioning, we have intersex, we have pansexual, we have 2S for two-spirit, we have asexual, and we have allies or supporters of LGBT community, which many of us among us are. So we have to differentiate what is sex, what is gender. What is actually sex? Sex is what is assigned at birth based on the appearance of the external genitalia. When the external genitalia are ambiguous, other indicators, example, internal genitalia, chromosomal and hormonal sex come into play. Basically, it is the physical, biological, and chemical makeup of an individual and simply refers to the biological difference between men and women. Gender. What is gender? We many times, without knowing, use one for the other. So gender are the attitudes, feelings, and behaviors that a given culture associates with a person's biological sex. Gender is actually complex. The people that feel they fit in anywhere in between the two or with neither. They feel that they might be, this way or that way or in between. Biological gender is an oxymoron. The biological aspects are not gender related and the gender related aspects are not biological. So it is a little difficult term. Maybe this slide will make you understand it better. So difference between gender and sex. Sex is biological. Gender is the socio-cultural context of the sex comes from nature. Gender comes from society. Sex is constant. Gender might be variable. Sex is based on chromosomes, internal and external sex organs, and the other hormonal activities within the body. But gender is variable as well as changes with time and culture. So what is gender identity? Gender identity is a person's deeply felt, inherent sense of being a boy, a man, a male, a girl, a woman, or a female, or an alternative gender. Example, it may be gender queer, gender non-conforming, gender neutral. It may not correspond to sex assigned at birth or to primary or secondary sex characteristics. With the next slides, it will be clearer with what I'm trying to talk about. So gender identity is internal. It is not necessarily visible to others. It's not like some external genitalia that it's visible to others and that, yes, I have two breasts, so I'm a woman. So what gender is internal, what I feel. Next is sexual orientation. Many times we confuse gender identity with sexual orientation. Sexual orientation is actually a component of identity that includes a person's sexual and emotional attraction to another person. So I might be a male gender, but my attraction to another gender is what defines my sexual orientation and the behavior and social affiliation that may result from the attraction. So a person may be attracted to men, women, both, neither, or to people who are genderqueer, androgynous, or have other gender identities. Individuals may identify themselves as lesbian, as gay, heterosexual, bisexual, queer, pansexual, asexual, aromantic, many other terms. There are tens of terms used for them. So what is cisgender? Cisgender is what we assume somebody to be. It's an adjective used to describe a person whose gender identity and gender expression align with sex assigned at birth. So I have a penis, I prefer my pronoun to be he, and I identify myself as a male. So I'm a cisgender man. I have a vagina, I like to be called as she, I identify myself as a female, so I'm a cisgender woman. So this is cisgender. So what is heterosexual? Heterosexual persons primarily emotionally, physically, and sexually attracted to members of the opposite sex, also known as straight. Anybody who comes to us, we assume that the person is heterosexual, never giving respect to what he or she might be feeling or thinking or practicing. What is a homosexual? These are persons primarily emotionally, physically, and or sexually attracted to members of the same sex or gender. This term is considered stigmatizing due to the history as a category of mental illness, which has been removed now. Homosexuality is not a psychiatric illness anymore. Please be clear about it, and is discouraged for common use. So we use the term gay or lesbian instead of using the terms homosexual. Lesbian, women who are primarily emotionally, physically, or sexually attracted to women. Gay, individuals who are primarily emotionally, physically, or sexually attracted to members of the same sex or gender. Commonly refers to men who are attracted to other men, but can be applied to women as well. Bisexual, we see a lot of bisexuals nowadays, a person who is emotionally, physically, and or sexually attracted to people of their gender and another gender. So they are attracted to the same gender as well as the opposite gender. This attraction does not have to be equally split or indicate a level of interest that is the same across the genders or sexes. Primarily, they might be homosexuals and they might show some heterosexuality. So it is not that they are equally distributed. It might be one end to another end. Transgender, these are gender identity and or gender role do not conform to what is typically associated with a sex assigned at birth. So we have trans man, which are female to male transgender people or transsexuals, signify that they are men while still affirming their history as assigned female sex at birth. So they are born as females at birth, but they feel, they want to express themselves as male. So these are the trans men. So women to men. Trans woman is male to female transsexuals or transgender people to signify that they are women while still affirming their history as assigned male sex at birth. So the male that at birth they are assigned the male sex, but they practice themselves or they express themselves as females. Bi-curious, it's a curiosity about having attraction to people of the same gender, sex, similar to questioning. So it is basically, am I attracted towards the same sex? It's just being curious. Another term that is used is asexual. These are people who experience little or no sexual attraction to others or lack of interest in sexual relationship or behavior. This is a continuum from people who experience no sexual attraction or have any desire for sex to those who experience very low levels or sexual attraction only under specific condition. And many of these different places on the continuum have their own identity labels, also known as demisexual. Asexuality, don't ever, interchange asexuality with celibacy, because celibacy is sexual, it is a sexual orientation. Asexuality is a sexual orientation, whereas celibacy is an abstaining from a certain action. Even though I want to do, I'm abstaining because I am a celibate. Not all asexual people are aromantic. Questioning is again an individual who, over a period of time, when someone is unsure about or exploring their own sexual orientation or gender identity, they're exploring, they're not sure about whether they're male, they're female, the homosexuals, the heterosexuals, or the bisexuals. Queer, it's an umbrella term. Individuals who don't identify as heterosexual, a non-normative gender identity, used interchangeably with the LGBTQ term. Historically, it is a derogatory term. Not all people are comfortable with the use of term queer. So we have to be very, very careful when we use such terms. And lesbian, gay, bi, trans, intersex, pansexual, everything comes under the umbrella. This is actually an umbrella term. Genderqueer, that does not align with binary understanding of gender, does not identify fully as either a man or a woman, may redefine gender or decline to define themselves as gendered altogether. They tell that I have no gender. Both man and woman, they may be bigender, pangender, androgyne, neither man nor woman, genderless, gender neutral, neutros, agender, moving between genders, gender fluid. So sometimes they will identify themselves with a male, sometimes with a woman, sometimes with both, many times with neither. So these are the various symbols used: male, female, hetero, transgender, gay, lesbian, many symbols. MSM and WSW, these are men who have sex with women, or men or women who have sex with women, to distinguish sexual behaviors from sexual identities. Because a man is straight, it does not mean he's not having sex with men. Often used in the field of HIV, AIDS education, prevention, and treatment. Androgynous is another term. There's a gender expression that has elements of both masculinity and femininity. Many times we see women dressing as men, men dressing as women. These are the typical expressions of androgynous, usually used in place of intersex to describe a person with both female and male anatomy. Dyke, this is a masculine presenting lesbian. While often used derogatorily, it can be adopted affirmatively by many lesbians as a positive self-identity term. So many times this naming, shaming is used as a means of becoming stronger and showing to the world that yes, even with this name and shame, we can come out. Faggot is another derogatory term. It refers to a gay person or someone perceived as queer, used as a self-identifying affirming term by some gay men. At times it is shortened form is fag. Ally, heterosexual or cisgender person who support and respect members of the LGBT community. They need not be part of the LGBT community, but they express their support, they come out in support. And coming out as an ally is when you reveal or take an action that reveals your support of the LGBT community. Many allies go through a coming out process of their own. Heteronormativity, the assumption in individuals or in institutions that everyone is heterosexual, that is wrong. Example, asking a woman if she has a boyfriend. I ask a woman if she has a boyfriend. If she tells no, I ask whether she has a girlfriend. And many times I get a very, very positive answer. Heterosexuality is superior to all other sexualities. Invisibility and stigmatizing of other sexualities. Only masculine men and women are straight. That's a wrong concept. Homophobia, that is what we are trying to get over. Negative attitudes towards the LGBT community. There's fear, there's anger, intolerance, resentment, a lot of negativity, discomfort. The connotative fear, disgust, or dislike of being perceived as LGBTQ can be extended to bisexual and transgender people. That is biphobia and transphobia, and may be experienced inwardly by someone who identifies as himself as queer. That is an internalized homophobia. So there's the biological sex spectrum, male, female. In between there is intersex. Gender identity, we have man, woman, and the third gender. gender expression, we have masculinity, we have femininity, and androgynous. Coming out is the process by which one accepts or comes out to identify one's own sexuality or gender identity, the process by which one shares one's sexuality or gender identity with others. This is a continuous, lifelong process and might take 10 years, 15 years, 20 years to the person actually come out with the whole thing. So black, white, gay, straight, religious, atheist, you, we all have the same structure, we have the womb skeleton, we have the same blood. Why differentiate? Why distinguish? Why create such a lot of naming and shaming? Thank you so much.
Thank you very much, Dr. Amrit, for this wonderful and very important talk, because it is first step towards accepting is to know what you're accepting, to know various terminologies, and it's very important, as you mentioned, to use the right terminologies. And I want to just reiterate, about sexuality, that it is an emotional, physical, and/or sexual attraction towards the same or the other gender, and it's not just sexual, which is what most people believe, that it's about sex. It's not just about sex. It is about emotions. It is about your feelings, and there are various layers to that. And coming out is also, as you rightly said, a completely lifelong process. You keep coming out to various people throughout your life, and each time the experience is very different. That brings us to the next and the last talk of the day by Dr. Avinash D'Souza. He's going to talk about the myths about LGBT community. And Dr. Avinash D'Souza is, I'm really pleased to be here to introduce him. In 1995, on the first day of our anatomy dissection in the medical school, Dr. D'Souza was standing next to me while we all were like, stooping onto the cadaver and trying to dissect out. He stood next to us looking slightly disinterested. And when we asked him, why are you not interested? Like, this is fascinating. There's a dead body we have to cut open. I just, I'm going to become a psychiatrist. I don't need this. So on day one on med school, when we didn't even know if we are going to pass the first year, he knew that he's going to be a psychiatrist. And here he is. He's a consultant psychiatrist in various hospitals across Mumbai, including our alma mater, Sion Hospital. And he's also the founder, trustee of D'Souza Foundation in Mumbai, who's doing a great job for the mental health professionals and the community of awareness and doing various academic programs. Over to you, Dr. D'Souza.
Good evening, everyone. And my talk is going to be on the myths and facts related to the LGBT community, because a lot of people who work with the community don't realize that there are a lot of myths and facts which are floating, and we aren't really aware of them. We probably assume certain things to be true when they're not true. And this is something that I think not only medical professionals, but everyone watching this seminar or webinar has to know. At the outset, let me tell you a few disclaimers that I have not covered all the myths and facts, because it's not possible to cover all of them in the time frame given to me. So I may have missed out a few. I didn't mean to hurt sentiments of anyone from the community by missing out a few, but I have covered the more common ones. One of the commonest myths that most medical professionals and people have is that members of the LGBT community are unknown to me. So very often, we feel, well, why should I attend a seminar or a conference or a talk on the LGBTQ plus community? Because I don't know anyone from there. But what you actually don't know is probably you have people around you who belong to the community and are found in every walk of life. And probably you may not be aware because they haven't come out to you. They haven't told you. And there's no way looking at them that you'll probably always know that they belong to the community. So you really don't know that you have very often many people around you that belong to the community, that work just like you and I work, that are normal individuals. There is no problem at all. They're living lives just like you and I live. And very often what happens is that we think, oh, I don't know anyone from there. So that's one of the first myths which is there. A very common myth, a rather primitive thinking kind of myth which exists, is that members of the LGBTQ plus community are promiscuous in nature. and I mean sexually promiscuous, and they feel that, oh, these are people who probably are constantly looking out for sexual partners. But the fact is that members of the LGBTQ plus community are just as likely to be single, partnered, live with their partners, be in a relationship, live with people who they love, just like you and I love the people who we love. So they are as sincere in their relationships as we are. So it wouldn't happen that you have to worry about, say, a member of the community getting sexually promiscuous with you because you're sitting next to him and he might want to propose a sexual act. No, that doesn't happen. But this is the nature of our society, which is homophobic and thinks in this way. So we have to understand that no, they are as sweet as we are, they're as sincere as we are, and in their relationships they're as cordial and sincere as we all are. Another common myth which does appear is that members of the LGBTQ plus community do not experience problems and domestic violence in their close relationships. But what is very, very important to understand is that members of the community may experience domestic violence, just like is seen in all other heterosexual relationships. They have their fights, they have their disagreements, they have their arguments, and they may sometimes be victims of a relationship where one partner is very dominant, and there, as a result, there may be violence that happens, there may be aggression that happens. But however, one thing to note is the reason why we don't know about this is because it goes underreported. They are members of the community are reluctant because of the homophobic and heterosexist nature of society to go and complain to the police, to go and complain to the authorities. There isn't really a portal where people work for domestic violence issues in the community, so therefore they may not report it, and we feel that it doesn't occur. So it's underreported, and it definitely occurs. uh, a very important myth that prevails is that members of the LGBTQ plus community should not have children. Let me tell you, across all the studies done all over the world, there is no evidence to suggest that children brought up in same sex or transgender households would negatively develop. There is no evidence to say that children brought up in the same sex or transgender households would have their sexual orientation altered from an early age, or being in those kind of households would have a negative impact on their emotional well-being and sexual orientation. Not at all. In fact, members of the LGBTQ plus community can be as sensitive, caring, loving towards children as we all are, and they can be as good a parent as we are. A common myth that is also prevalent is that members of the LGBTQ plus community may engage in child sexual abuse due to their hypersexual or sexual promiscuous nature. Again, there is no evidence to support that members of the LGBTQ plus community engage in child sexual abuse. In fact, most of the reports, most of the literature done over the past 5 to 6 decades on child sexual abuse often reports child sexual abusers or offenders to be heterosexual in their orientation. There is no report that looks at members of the community being involved in this. In fact, members of the community may themselves at times have been victims of abuse in their young age, but they've never really turned the aggressor or turned the oppressor, and that has never really happened. Another myth is that bullying and violent crimes against the community are low. That's not true at all. In fact, there is a lot of evidence to suggest that members of the community may often be victims of bullying. There may be a workplace bullying, there may be bullying in colleges, there may be bullying at a university level, they may be victims of cyberbullying, they may have to face taunts at the workplace, they may have to face violence at the workplace. And even when they are studying in a college or a university, particularly in certain countries or certain quarters, there may be homophobic tendencies that they have to face with. Another myth that comes up is that suicide rates, and I would even add rates of depression in members of the LGBT community, are low compared to others. But that's not true. In fact, over the last 2 years, ever since I've been part of the IPS task force, I've had a lot of patients from the community come to me for help. And there is definitely evidence to suggest that members of the LGBT community may be more prone, in fact, to depression. They may be more prone to self-injurious behavior. They may be more prone to feel suicidal or attempt suicide in view of the various kinds of trauma that they face. And this also happens. It's also important to tell you that sometimes the causes of depression, there are very often specific causes related to the bullying, the workplace harassment, the homophobic attitudes that often lead to depression. So there may be factors unique to the community that cause depression in them. Lack of acceptance by family members and lack of acceptance by close ones is one of the common causes also. A common myth also that prevails is that all members of the LGBT community abuse alcohol and drugs. Now, this may not be true because we've not found substance abuse rates and alcohol dependence rates to be higher in members of the community. But one of the things is that members of the community are stressed due to various factors around them. They face loneliness, isolation, trauma, and they may be more prone to use alcohol and drugs to cope with their stress, because they very often use it as a coping mechanism to drown their sorrows and drown their troubles. But the rates of use are very similar to that of the general population. There is no increase in the rates of use here. Also, a common myth is that members that belong to the LGBTQ plus community are usually well educated and rich, and it is something that you see only in the upper strata of society. This is not true. Being at Sion Hospital, which is a municipal hospital where we see patients from the middle class and the lower socioeconomic strata, we have seen a lot of patients from the LGBTQ plus community that come in. Therefore, I would conclude that members of the community come from all walks of life, all social strata, and varied educational qualifications. It doesn't necessarily mean that because you're highly educated, you are more likely to be open-minded and move towards expressing your sexual identity. You see it across all strata and all educational sectors. A lot of people feel that members of the LGBTQ plus community do not face discrimination at work. Even at a higher level, at a corporate level, at a work level, it's very true that I have come across people from the community who tell me that they face widespread discrimination in the workforce. When it comes to promotions, when it comes to projects, when it comes to being given work, when it comes to being assigned leadership roles, when it comes to being assigned team roles, there is a lot of issues that they face at the workplace. So this is something which is also very prevalent. One of the other myths is that members of the LGBTQ plus community can use health and mental health services very freely. Now, this again is very difficult because sadly, not many members of the medical fraternity are sensitive to the needs of LGBTQ plus populations. So they may face stigma and ridicule during the use of health service. And also not all mental health professionals are equipped to deal with these issues. Therefore, it's very important to understand that they need to be visiting health professionals who are sensitized to their needs, who are sensitized to what their problems are, who also know the use of appropriate terminology so that they do not face any kind of discrimination. Another myth is that members of the LGBT community are non-religious. This is an absolute baseless myth because members of the LGBTQ plus community may be as religious, as devout, and as spiritual as anybody else. So being atheist does not make you more prone to belong to the LGBTQ plus community, and members of the LGBTQ plus community are no more atheist than the common group otherwise. So I don't think we need to think on those lines. Another myth is that members of the LGBT community do not experience sexual dysfunction. Again, this may not be true. And in fact, we don't really have sexual medicine experts that deal with problems specific to the LGBTQ plus community. But let me tell you, their sexual relationships, the sexual act, the neurobiology, the physiology is all the same as any sexuality, and therefore they experience sexual dysfunction like maybe premature ejaculation, erectile dysfunction, sexual desire issues, which are just like members of the general population, and they need to be treated just like any other individual coming for help. A common myth which is present, again, primitive thinking, is that all members of the LGBT community may have HIV or AIDS. This is not true, and all reports in various HIV or AIDS journals have very clearly shown that, in fact, members of the LGBTQ plus community may have lower rates of HIV or AIDS than the heterosexual population. So it's not that they are more prone to develop these disorders. A very important myth is that people believe there are very few elderly that belong to the LGBT community. This is not true. And I think many older people are present currently, living currently, that belong to the community, but probably haven't come out all these years because of the various issues that were there. And they have now come out very often because they feel that it's safer and it's more secure today to come out. In fact, there is a group of older individuals known as teenagers, which is a group specifically for the elderly that belong to the LGBTQ plus community that is there. A lot of people think that belonging to the LGBTQ plus community is a matter of lifestyle choice. Well, let me tell you, LGBTQ plus community and our sexual orientations in general are not lifestyle choices, but rather there are many factors that determines one's sexual orientation, that determines one's sexual preference. This starts during the developmental phase and matures as we mature into adults. There are neurobiological factors, there are psychological factors, there are environmental factors, there are personal preferences. So nowhere belonging to the LGBTQ plus community is a matter of a lifestyle choice. I end with this quote by Pope Francis: if someone is gay and he searches for the Lord and has goodwill, who am I to judge? We shouldn't marginalize people for this. They must be integrated into society. Thank you.
Thank you very much, Dr. Avinash, for that very lucid presentation about the myths. And you're absolutely right. There are so many myths. And Dr. Jyoti Shetty, who has joined us from Pune, has also pointed out what you mentioned, that many of these myths are actually quite prevalent in the healthcare professionals itself. And that's the whole point of these webinar, that we bust those myths. So we'll take the question and answers now. And there have been few questions that have come up. And I have also noted down a few questions that popped into my mind. So Dr. Bhugra, are you here?
Yep.
So, yes. So the first question that we have is, it says basically, it's a comment. I think you may want to sort of dwell upon it. That Dr. Bhugra labels trans as hijra, and I don't think trans community would agree with it, as hijra community is just a fraction of trans community and doesn't represent trans community.
I agree. I mean, I think one of the big challenges, and we've heard it in terms of heterogeneity and question of definitions. I mean, I think the reason I did not have time to go into hijra versus trans, because there are very different issues. And as far as I am aware, India is the only country which has now identified third gender as a possibility. So that raises some very interesting questions. And I think I go back to the heterogeneity nature, and just to assume that all gay men and lesbians and bisexuals will behave in the same way is not possible. Individuals are individuals, and their upbringing, their attitudes, their support, their own perception and micro-identity and identity are going to be very much dependent upon a number of factors. So yes, I agree that I'm not saying that all hijras are transgender or the other way around, but it's just to highlight that cultures play a role. In the Indian subcontinent, hijras appear in India and Pakistan, and they have some kind of social role as well. Particularly, that in Hindu weddings, they come and dance or whatever. So there are specific functions allocated. So it's not that they are waiting to have their gender changed. So it's just to indicate that it's a very complex topic.
Yeah, absolutely. And as you rightly said, hijras are an integral part of not just the trans community, but as a India as a whole country. Hijras have played a huge role for hundreds of thousands of years in our culture. And unfortunately, because of the colonial laws, they have been marginalized now. And I'm really happy to see that there are various initiatives that have come up now who are supporting the transgender community as well as the Hijra community here in India. So the next question is it medically accurate to identify the physiology of male and trans men, who's basically a woman to male transition, post-transition, or are there differences?
Physiologically, post the corrective surgeries that we do, suppose somebody is a trans man, so from a woman, he's converting to a woman. So physiologically, suppose we are taking, you're doing a mastectomy, you're doing a, oophorectomy and a hysterectomy. So maybe physiologically, once those things are out, we can, in terms of physiological identification, we can only do it post the surgery. But I think that is it a legally binding thing, or it just?
Yeah, and it also, I think, I mean, it depends on how do you define physiologically, because it's a very tricky sort of question. Gopal, I think you've landed up sharing your screen with us. Okay,
Yes.
we're back to our videos. All right. So, Abrid, the next question is for you, where one of the participants has asked, and it's a very interesting, with a lot of cultural context to it. And I don't know if you have the right answer for that, is women who prefer to choose another lady as an emotional anchor. How is it different from that of a woman being homosexual, attracted emotionally to another woman?
Yeah, I went through the question. Basically, even in our definition, we have discussed sexual orientation as a component of identity. It includes a person's sexual and emotional attraction to another person. So there is two components to it. One is the emotional component, one is a physical component, and the behavior and social affiliation that may result from this attraction. So if you are emotionally attached to somebody, but your behavior is not like that, and maybe socially you are not affiliated, it might just that be an association. But once there is a physical component to it, your behavioral changes are there, and then maybe you are affiliated to in the society on those terms, we might term it as homosexual. So that is where we can just there's a fine line, but then we are emotionally attached to maybe my friends, close friends. Physically there might be zero attraction. So if there is no physical component in terms of sexual attraction, we might just call it as an emotional attachment, not give a lot of terminologies to those things.
Like the current term is bromance.
Romance.
Are you indulging in bromance?
Yeah.
But I think that two other things that we need to bear in mind, the sort of concept of yar and concept of Saheli are very important in sort of both history and literature. Some people seem to have interpreted that as same-sex attraction and behavior. And I think we need to be very clear that it does not automatically translate that into same-sex attraction. It could be friendship. And, consistently, the concept of yar with God in Sufi poetry. So one can't sort of see that as, sexual. It is devotion. It is friendship. It's, dedication. So we just need to be careful that we don't muddy the waters.
Right. I think also we need to be aware of this as a non-sexual rather than an asexual matter. I remember seeing the movie Sholay with visiting in Western psychiatrist, and he saw this movie Ye Dosti Ab Nahi Chhodenge, and he said this is clearly gay. So also Mahesh Dattani, a gay activist and playwright, mentions that when he was walking down one of Bangalore's well-known streets, not street walking, but he had seen. I mean, his visitor had seen people putting their arms around each other, and they thought, "Hey, this is a pretty liberated country for gays." So he said, "This is not gay at all. This is just a normal expression of friendship in India."
Yeah, indeed. Beautiful. Yar and Saheli. That's a wonderful way of putting it.
One unfortunate thing that we have, and this I think might come into Amrit's area of which you usually cover, Prasad, the terminologies. A very, very unfortunate word is straight. That which is not straight is crooked.
Bent.
So when people are talking about heteronormative orientations, then everything else is crooked. That's not. I wish that word straight would slowly have to be disbanded, or perhaps immediately.
Yeah, absolutely, sir. So the next question is, as IPS has done, which other central bodies of authority have declassified homosexuality as disease? And are there any bodies of repute that still classify it as disease, present status of conversion therapy in India?
Sir, do you have the statement, sir, which you gave, sir? Or shall I read it out?
You mean the one
Conversion
about...
therapy, sir.
No, that's the next
Conversion
question.
therapy, sir.
We haven't yet come to that.
Okay.
We are still asking about... I don't think there's any other body which has dealt with this issue at all. I don't think the IAPP or the Indian Psychological Association, Indian Association of Clinical Psychologists, has taken this up at all. But I know that the IACP have welcomed the official stance of the IPS in saying that homosexuality should not be criminalized and certainly should not be considered a disease.
Yeah, I mean, I think just to emphasize that, Royal College of Psychiatrists, American Psychiatric Association, DSM, and ICD have all taken homosexuality out, whereas the Chinese healthcare system still has. And there was a campaign in Indonesia about 3 years ago to re-include homosexuality in the classificatory system. So I think the message really is that we need to be watchful and make sure that we don't lose the gains and gains that we have made. But also in terms of, I don't know the scene on conversion therapy in India, but, perhaps Ajit or Avinash would be able to speak on that. But just to put it on record that conversion therapy is grossly discredited. American Psychiatric Association, Royal College of Psychiatrists, and the World Psychiatric Association have issued separate and joint statements saying that it does not work, and there's absolutely no reason to be given conversion therapy.
Right. Earlier this year, we had occasion to take this issue head on because we had the tragic suicides of a couple of cases, both as it happened from Kerala. And the Indian Psychiatric Society had to take an official stance where we clearly said conversion therapies do not work. We do not in any way endorse any of the conversion therapies. There was within the community, within the psychiatric community, a move to say that we should strongly condemn it. I thought we should go a little easy because we don't want to lose our fellow professionals. We just need to get them back on track to not practice non-medicine.
Dr. Bide, I want to point out something here that, when Practo shared this webinar on Twitter, there was one particular Twitter handle which actually shared screenshots of mental health professionals offering conversion therapy from Practo platform. And the backlash that was there is that while Practo is offering conversion therapy on their platform, they're trying to conduct this webinar, and there is a lot of discrepancy in here. So, and this question I get asked all the time: what do you, as a medical professional or as a medical professional organization, should do to stop this?
Amrit, you want to read our statement?
Yes, sir. I wanted to read the statement. This is a recent statement which the IPS came out under the leadership of Dr. Ajit Bhide. And sir was very wise enough to tell me not to use the word condemn. So I remember it because I was a little adamant that we use the word condemn. And sir told, no, Amrit, go slow. So the Indian Psychiatric Society in 2018, under the presidency of Dr. Ajit Bhide, categorically stated that homosexuality is not a disease and must not be regarded as such. All forms of treatment therapy, including individual psychotherapies, behavioral therapies like aversive conditioning, etc., hypnotherapy, group therapies, pharmacotherapy, physical treatment methods like ECT, etc., or milieu treatments to reverse sexual orientation are based on a premise that is erroneous, that such orientations are diseases. Moreover, there is no scientific evidence at all that attempts to convert a person's orientation succeed in any manner. The Indian Psychiatric Society totally disapproves of any such treatment and urges that such therapies must cease forthwith. The position statement for IPS is attached below. That is the position statement. And I think that is clear enough. And we have given it to, it's in our website. It has been distributed to all our psychiatrists. So it's a no from our side.
But it's still happening, right? The doctors are offering conversion therapy on Practo platform now. And that's the question that the
I'm
LGBT
shocked to learn
community
that.
has.
I wasn't even aware of this.
Yeah, it is very much there, and the names of the doctors are also displayed on the Twitter handle. So it's not, and it's happening right now.
I will. Can I just share an anecdote, sir? I got a call from Chennai, sir, from an undercover reporter, who asked me how many doctors. They talked about conversion therapy and asked me how many doctors are providing, and then they gave me some names of doctors who are doing it. There's an undercover reporter where I told I'm not involved in all these things. I want to give my comments. The IPS statement is like this, and this is this. There might be some people who are working on the people who are doing all these things, sir. So I got a call. I just wanted to share that this is happening, sir.
I think something similar in the UK when it happened, the relevant physicians were reported to the General Medical Council and full inquiries were undertaken. And if I remember correctly, they were struck off. So it's, one of the possible outcomes.
Since we are working under the aegis of the Practo organization, I think we should take a very strong stance today to say that Practo must not promote this form of treatment in any way. And we should educate people or try to educate people who mean to practice this kind of conversion. I mean, in this country, forced conversion is an issue for very different reasons, but this is equally bad, if you ask me. This kind of, it's something forced on young people. Let's be fair. I mean, the parents are very anxious to see what they consider normal. And they're acting in good faith. But that good faith is so bad, really, because they don't know the damage they're doing. So almost like Jesus Christ, we have to say, do we forgive them for they know not what they do?
So the next question is for, I think, Avinash. Why do blood donation restrictions still exist for people of LGBT community?
Well, I definitely, at least I can vouch for Sion Hospital and places where I work that I don't think that we have any blood donation restrictions. And I don't think there's any issue of them even mentioning about their orientation on a form. So I really don't know how, someone has got to that kind of a question, because neither do we have a blood test, neither do we have anything to, ascertain. So I don't think that's really a problem at all. Yeah, Dr. Bhide would want to add. Yeah.
No, you finished it, Ravi.
Yeah. Okay. No. So that was that. So that was my whole thing. Because at Sion Hospital, at least I'm very sure it isn't there. I don't know if there are specific hospitals where this issue comes up.
At the tail end of the last century, there was anxiety, especially in the context of HTLV3, as it was called then, and HIV, as we have since been calling it, that being rampant, they thought, only among homosexuals. And there was an anxiety that blood donation from these people, for people with HIV, can have a very variable incubation period. And that's where the anxiety came from. Can they be allowed to donate blood? Those doubts have largely been put to rest, and HIV is not nearly the scourge of the nature we have, for instance, now with this pandemic. And there is no cause for panic when people want to donate. People who want to be extra cautious do subject the donor to HIV testing before agreeing to take donations.
True.
Now, with COVID, there is another controversy that has started in India. I used to donate blood every 4 months earlier, and at one point I stopped because of this problem. So, there were forms which would explicitly ask you your sexual orientation, or are you promiscuous, are you married, not, and there were ways of doing that. Now, what has happened is there's a big controversy in the US that homosexuals who were COVID positive are not allowed to donate plasma for plasma therapy. And, so the discrimination runs at so many levels that even when you have a global crisis happening, we are not able to let go of discriminations. And it's really sad to see that it's happening everywhere. So the next question is, sorry.
these prejudices will be undone very, very slowly. We must not give up because they're there.
Yeah, absolutely. So the next question is, what should we do ahead? It's basically saying that the new MCI introductory MBBS course has a lecture on gender sensitivity. However, the LGBTQ is not specifically addressed, and this would help sensitize medical students. So, Avinash, what do you
Yeah.
have to say
Yes.
about this?
Well, I was fortunate enough to be lecturing the new MBBS batch that joined Sion Hospital, and I know, uh, uh, sadly, somebody from the basic sciences who approached me to take the lecture on gender sensitivity said that they are a raw group of new students, so please be very careful when you talk about LGBTQ plus, and we know you're very popular in that area and all that kind of thing. So I said, ki madam, gender sensitivity is gender sensitivity, so I will talk about, it's not, we're not talking about male female collaboration at the workplace. It is, gender is everything about gender. So I will go ahead and talk. So he said, no, they have, some of them are from rural backgrounds, they shouldn't feel shocked and this and that. So I said, no, I said I will go and talk. And in fact, I spoke and they were very happy. But two things here which I want to make is that sadly there is no chapter on LGBTQ plus for MBBS students. We do have one lecture which we take for them when they visit the psychiatry department, where we sort of sensitize them. But other than that, there is nothing for them, nothing even on the medical or hormonal or other issues, which may come up, which they need to at least know, that if somebody comes to them and talks about gender dysphoria, what to do. I mean, even basics aren't taught to them, as a family what they should do. And I'll tell you this, I had somebody, I think it came on social media, the forensic medicine textbook which is followed currently, there are 2 or 3 forensic medicine textbooks that still call homosexuality a criminal offense, and that hasn't changed despite our section 377 being revoked and all that. So probably even our forensic medicine people need to be sensitized and spoken to, in that regard. So because a second MBBS student came to me and said that isn't section 377 revoked, but in our textbook he said that when I wrote that in the answer I was given wrong. Can you believe that? So in the exam, so by whoever checked his paper. So I said, so probably your teachers need to be sensitized. They probably don't know. So this kind of a thing is there. Since we spoke about about reporting people who are probably engaging in this conversion therapy, I think one thing which, keeping the IPS statement in mind, I think state mental health authorities can get a little cognizant about this, and at least psychiatrists probably, I think, were doing something like this which may be wrong, could probably be, some action against them could be taken by the state mental health authorities if they want to, if it is brought to their notice. Since Dr. Bhugra is here, sir, I'll just take 30 seconds more. One of my research associates at Sion, who's also close colleague of yours, Dr. Kalra, Gurvinder Kalra, when he worked with me, we reported a letter in the Indian Journal of Medical Ethics about a psychiatrist. At that time, a patient came to us. We didn't name anyone, but we reported about this conversion therapy which was done. But this was 2008-9, way before section 377 was revoked. But we did report it, that how unethically a patient was admitted, treated, they tried to use aversion therapy in a private practice setting, sadly, to try and convert him, which of course didn't work. But the patient came to us with all his plight, so we did report it in the Indian Journal of Medical Ethics as a letter to the editor. Yeah.
Dr. Bhugra, do you have any comments about what's happening in the UK on this front, and how has the UK education system adapted to this?
I think it varies a lot. I mean, certainly, as you were talking, when I was training, the medical school that I was attached to, the first year medical students had the first 2 weeks when they started onto something called Medicine and Society module. So all these things were covered, and interestingly, at that time, they were discussions about pornography and its kind of impact on people, and various roles and things. And some people found it very uncomfortable and would walk out of the lectures because they just could not cope with it. So, I mean, I think it is, and this was about 35, 40 years ago. But the point really is that a lot of it is spread throughout. I mean, in psychiatry, I mean, I think as far as I remember, in India, you still have only 2 weeks of posting in psychiatry, whereas here, at least it's 6 weeks in fourth year, and you get some uh, learning in year one and year two, and some of the patients you follow up for a very long time from year one and year two. And part of your primary care learning would include bits about sexual variation and things like that. So it's not perfect, but it is there and much more. And I think one of the big challenges, and I know that Indian Psychiatric Society had been fighting for a long time to increase the duration of training in psychiatry, because I mean, I know that people, who are not interested in psychiatry don't want to spend 2 weeks going into an asylum. And so the challenge also is about the curriculum, where you train them, how you train them. If medical students are taught much more about common mental disorders rather than very serious mental illness, and they're more likely to be aware of things like depression and anxiety and phobias, and part of which may be attributed to minority status, whether that is to do with gender, sexual orientation, religion, kind of caste, then you can sort of create a different set of workforce. And I think that's a challenge that the organizations across need to take on and run with.
Thank you. Next question is quite interesting. Adolescents who are questioning, how do we manage them, and what age does it take usually before they identify their gender and or orientation?
So, shall I answer?
Yeah.
So generally, if you look at normal gender identity comes by the age of around 3 years, sir. But because of the severe stereotyping in our society, where they tell that this is, you have to do like this. So maybe by the age of 5 to 6 years, the children are little, adamant about the gender. But there are certain, if you look at gender dysphoria, when we are, when people come to us talking about gender dysphoria, so we have basically 2 or 3 approaches. Either we support them in their gender expression, or there is the Dutch approach where they leave it like that. Sometimes, you might kill me for sitting in a platform like this and talking like this, but then many times, like what Dr. Bhede was telling, the parents are very, very anxious. They are not as psychologically developed as we are. They have their own apprehensions. So they will come to you, ask you about things. So we tell them, okay, let them be the way they are. Let them develop. They are questioning themselves. Might be sometimes, it changes. So it's a little fluid. It is little not very, very crystal clear. But maybe by the age of 8 to 10 years, they are absolutely adamant about how they want to express themselves as. Prashad, can you add anything beyond what?
As a follow-up question, there is a question that is it illegal for a psychologist or a psychiatrist to talk about this to somebody who is under 18 without parental consent?
Talking, I think it is never illegal to talk to somebody about their issues, but maybe when you're talking about, sex change or, gender dysphoria, treatment for gender dysphoria, we have a system where we can, 16 is the cutoff in certain countries, 18 is the cutoff in certain countries. And they're very, very clear about things. It is not about parent, it is a guardian. Even an uncle can be a guardian. There is a caveat in the whole, if you look at the criteria, there is a caveat which we can use. Even a close family friend can be a guardian, somebody who is an ally can come with the patient, and then you can talk. So that it is not illegal. Nowhere in the law it is written that the parents have to come. There has to be, if there is some decisions about gender changes have to be made in terms of any operation, in terms of hormonal therapy. If the patient is not 18, let us be safe. Let us take the cutoff age as 18, and maybe a guardian, not even a legal guardian, is sufficient.
Avinash, do you have something
yes.
to add?
See, since I work in schools, one of the things I want to mention is that many a times, I've had psychologists who've referred children in the 9th and 10th standard, who are a little confused about their sexual orientation, and they come to you and say, I think I'm gay or I'm probably lesbian. And at that time, I remember very often we call in the parents, for a session and speak to them. And I've had a number of parents who often told me that, how did you sort of even have this conversation? And I've actually gone and told them that, I'm not the one who started the conversation. It's your child who came and spoke to me, so that's how I had to speak to him. It's not that I went and asked him or her about the orientation aspect. That's one. And we faced opposition. I don't say it's illegal at all. I totally think you can talk. I totally agree with Amrit. But we have faced opposition when we've tried to involve this LGBT sensitization in sex education for adolescents. We've had a lot of principals, a lot of teachers who've said that that is not sex education. So but then at the same time, we've had principals who've been also open and told us, please, go ahead and uh, include it. We don't mind. So both ways.
We are on the last question for the evening, and we have had a wonderful session until now, almost 1.5 hours. The last question is, does upbringing, surroundings, which the parent is offering to the child, have an influence on their orientation, sexual orientation? I can see Dr. Bhugra giving a big smile. Dr. Bhugra, do you want to comment on that?
The short answer is no, because it's innate. And, most of us know at a fairly early age. So the bringing up can influence the way you deal with it, the way you come out, the way you express yourself. But it's, the point that was being made earlier about sort of children, brought up by LGBT individuals, why do they not grow up to be LGBT individuals? They don't. Not everybody. So, if that were the case, then everybody brought up by LGBT individuals would be LGBT. And it doesn't happen. So, I think the message really is that it's innate. It's the social cultural responses which affect the way we behave, hide, come out, respond, seek help, express our distress. So we need to be very clear that, environment doesn't turn you into who you are. I mean, there will be debates, and I think we do need more work, particularly from different cultures, to see how cultural factors influence. And, there's always a stereotype, which is that if you've been abused as a child, if you're a male and child and you've been abused by a male relative, you're more likely to, or male another person, but you're more likely to become gay. It doesn't always work like that.
I think with the single exception of facultative homosexuality, which does occur, for example, in boarding schools, on people at sea for long periods of time.
But you see, that's behavior. It's
Correct.
not orientation.
Correct. But there's this, I take examples from literature very commonly, and in one of Arthur Haley's books, I think it's The Money Changers, but I'm not dead certain about the particular book, where a heterosexual man involved in a scam, is in prison, is in jail, and this is based on a true story. And over there, he has to seek the protection of one of these big, burly, not being color prejudiced or whatever, a black man who gives him the protection. And then they become very close, and it becomes a romantic relationship. And when after his prison term is over, he is pained to say bye-bye to his protector lover, and he cannot engage in heterosexual intercourse for some time. There are exceptional cases like that, but by and large, what Dinesh says is true. It is inbuilt. And as Dinesh said, the debate about this is not complete. It will go on, but innate factors are far more important than the extraneous and cultural, social factors.
I think that's the point in terms of, you could be a heterosexual man by orientation, but indulge in homosexual behavior while having heterosexual fantasies. So it's kind of, fantasy, orientation, and behavior need to be, and part of the challenge of conversion is that it's focusing on behavior not on the orientation. And quite often people confuse the two.
There is a
And that's
provocative
where this,
question. Sorry, Prasad, there's a question about pedophilia, which we've totally neglected.
is it? Okay. Let me just go back because there are so many comments and questions.
Yeah, there is also one question for you, because since of HPQI, you know, they ask, are there any guidelines or SOPs to make a hospital LGBTQ plus friendly, which I felt was very nice.
Straight up your street.
Yes,
Yeah.
yeah.
So, you know, Avinash, that question, Dr. Jyoti Shetty, who's a psychiatrist
Okay,
in
okay.
Pune, she has actually answered that query and she has the guidelines. And
Okay.
she's been very kind in saying that she will share those guidelines. So I'll
Sure.
request Practo to share that guideline with everybody who has registered for this webinar. And we can also share it on our social media
Sure.
so that more and more hospitals have the knowledge of doing it. And Dr. Jyoti has been running a specialty clinic for the LGBT community in Bharati Vidyapit in Pune very successfully. And, you know, I have referred many people to her and she's been very kind in accommodating and getting them on. So the question on pedophilia is, how do you see pedophilia and other paraphilias regarding myth number 14? I think, Avinash, this question is for
Yes.
you.
Well, see, like I mentioned, I mean, I think we've spoken about it now. Dr. Bhide spoke about it. Bhugra sir has spoken about it. That it doesn't happen that, you know, if say you have been abused or there's been male to male abuse, that you would turn out to move towards the homosexual orientation. So even if somebody, probably, I mean, and I think what they're talking here is about a male person who engages in pedophilia. Now, if he does engage in pedophilia with young boys, well, pedophilia is very different, I think, from being in a homosexual relationship. So pedophilia is an offense. It's a paraphilia. We regard it under the classification as a paraphilia. So that is a totally different thing, and we wouldn't, I think, put that under the gay category or the homosexual category at all. So that would be treated differently. And I think KM Hospital at Pune is doing a youth study on offender rehabilitation for pedophilics. So I think and that's a totally different area. It's not at all related to the LGBTQ plus thing where.
No, I think we should take a categorical statement saying pedophilia is pathology. No
yes,
two ways
yes,
about
it is. It is.
We
It is.
need to
Yes.
say that
Yes.
categorically.
Yes.
Because I was at another seminar in Kolkata 2 years ago, organized by Ratnaboli, who does a lot of work in mental health. And that one was specifically with mental health and sexuality. And I had to encounter people who were advocating something called ethical pedophilia. I've been stunned out of my wits with this kind of notion. And there is a forum for it in India. Ethical pedophilia, if you please. I think it's an oxymoron if you ask me. And nothing can be ethical about pedophilia to my mind. If you have fantasies that are pedophilic, you need to have them handled with professional help.
Doctor told me on Facebook telling that tomorrow you will legalize pedophilia.
And bestiality. The moment you talk about homosexuality not being criminal, I mean,
a senior psychiatrist wrote to me in a group, sir, WhatsApp group, that when are you legalizing bestiality? So we have been heavily trolled.
So Dr. Avinash and Dr. Amrit, we have a big battle ahead. I think our careers will be fighting these battles. But the important thing is that we, as Dr. Bede said, we must keep this fight on. We must keep doing these awareness sessions to increase the awareness and get everyone on the same platform of equality and promote diversity. Any last comments from any of the speakers?
Just to say thank you very much for chairing and bringing together a wonderful group on the panel, and keep up the good work. Thank you very much.
So thank you very much, everyone, for joining in, especially Dr. Bhugra, all the way from morning in London, to Dr. Bide from Bangalore, Dr. Amrit from Bhubaneswar, and Avinash and I from Mumbai. Thank you very much. I just wanted to say one last word that, you know, if you don't take away anything from what we discussed now, the one thing that I would really request you to take away is that any person who walks into your clinic, just be aware that that person may not be cisgender or may not be heterosexual. If you just take away this much, I think we have won half the battle. And the next is details. So thank you very much, everyone. Have a lovely rest of Sunday. And we look forward for you to join the next webinar, which is on the following Sunday on 23rd August at 4 p.m. And we have, again, excellent panel of speakers, including Dr. Ajit Bhide, Dr. Kersi Chawda, and Dr. Suresh Badamat. And we again have very interesting topics to discuss. So please don't forget to join in on next Sunday. Have a lovely time. Bye-bye.
Thanks for wonderful sharing, Prasad.
Yeah, bye.